Hi, everybody. Thanks for joining. This is the November 2022 Wellness Medicine Journal Club with Virginia Tech Carilion. This month, we're talking about ticks. We're going to be going through the WMS guidelines, covering a couple articles, and we've also got one of the guideline authors here who's going to work through some cases with us. I think it might be kind of fun to intersperse the cases throughout to keep things fresh. So, Joe, whenever you are ready, I've enabled share screen. So take it away and get us started with the guidelines.
Sorry about that. I shared my screen and my computer immediately froze. So here we are. Can you all see my slides?
Looks good.
All right, and got it in presentation mode right now? Perfect. All right, so my name's Joe Mueller. I'm an M4 from University of Iowa, and I'm gonna take the lead in presenting our WMS clinical practice guidelines for prevention and management of tick-borne illness in the US. And these were released in 2021. We're really fortunate to have Dr. Stephanie LaRue here tonight to help out. And these guidelines, they focus a lot more on like field management and prevention. So you'll see that as we go through the different slides. But just some background, ticks and human illness, 95% of US vector-borne diseases are attributable to tick-borne pathogens. We're going to go through the prevalence of the different tick-borne diseases as we go through the slides. We're going to do kind of a quick overview of each one. But Lyme disease is by far the most prevalent in the United States. Transmission usually from vector to host, or it's between vectors on the same host. And we can see here kind of the classic tick habitat. It's going to be either wooded or grassy areas where they like to find their mammalian hosts. And I put here a picture of the Appalachian Trail going through Pennsylvania, both because it's a very like well-traveled wilderness area in the United States, and the northeastern US far and away has the highest prevalence of Lyme disease in our country. Ticks sense heat, exhalations, vibrations, and odors in order to attach to their hosts. They have a lot of enzymes that they release that can facilitate transmission and also facilitate pathogenicity of the different illnesses. So these can be things that like decrease platelet aggregation, inhibit the clotting cascade, inhibit like the inflammatory response of the host, increase blood flow, but also increase the ability to transmit. And there's a brief mention of anthropogenic change and deforestation, climate change, overall contributing to expanding tick habitat and population within the guidelines. So here we just have kind of a brief overview of some of the different species of ticks mentioned in the guidelines. In picture A, we see Ixodes scapularis. This is the blackleg tick or the deer tick, one of the ones that carries the most pathogens of any of the ticks we're going to discuss today. This is Lyme disease, anaplasmosis, ehrlichiosis, babesiosis. Next, we've got the Lone Star tick, the Amblyomma americanum, aptly named because of the Lone Star on its back. Ehrlichiosis and tularemia are going to be the main ones transferred by this tick. And those are going to be, it's found more in the south and eastern United States. C and D, we have the two dermacenter ticks. In C, we have the American dog tick. And D, we have the Rocky Mountain wood tick, most commonly associated with the rickettsial diseases, Rocky Mountain spotted fever. E is just a general kind of guide showing the increase in size of ticks through life cycle. Oh, can you hear me better now? Perfect. So we've got an increase in size of ticks as they go through their life cycle from larva to nymph to adult. And then F just shows the kind of vast increase in size as ticks feed on a blood meal. And Here, the main point I'm kind of trying to get across is the general correlation and overlap between the specific ticks that carry a disease and the habitat of that tick. So we can see the Ixodes blackleg tick, and that overlaps pretty well with Lyme disease, anaplasmosis, babesiosis, the ones that it carries. We also see some Lyme disease on the West Coast, and that's going to be due to the Western blackleg tick, the Ixodes pacificus. We have the Lone Star tick overlapping pretty well with ehrlichiosis. And then we see our dermacenter ticks as well as our brown dog tick. And those show kind of the overlap with Rocky Mountain spotted fever in the South Central United States, as well as throughout the rest of the country, Rocky Mountain spotted fever can be found. And very important point, providers must be prepared to diagnose and manage TBI without definitive tick identification. So just kind of showing you don't always have the tick at hand to know exactly what you're dealing with. So high clinical suspicion, especially with patients who've been in the outdoors lately with non-specific symptoms, and always want to keep these on the differential. All right. A lot of information was covered about the different diseases. I'm sure you guys are all familiar with the different diseases we'll discuss. We're just going to do kind of a quick overview of each one. We've got Lyme disease. These prevalences are based on the 2019 CDC numbers of tick-borne illness, which had about 50,000 cases. So each one you're seeing is a percentage of 50,000. So Lyme disease, again, going to about 70% of the tick-borne illnesses caused by Borrelia burgdorferi, Northeast, Midwest, and Pacific Coast states. The Ixodes tick has an incubation of about 3 to 30 days, and the stages that we're all pretty familiar with: fever, headache, myalgia, arthralgia in the early localized stage. And then you have that classic erythema migrans rash that we can see in our image to the right. This is going to be found in 70 to 80% of patients and can be up to 30 centimeters in diameter. Early disseminated is where we're going to see those more severe symptoms. We're going to have the multiple annular erythema migrans, flu-like symptoms. We're going to have some of the neuro symptoms like Bell's palsy. We can have Lyme meningitis at this stage. We can have neuropathies, and also cardiac symptoms, myocarditis, pericarditis, as well as arrhythmias such as heart block. Late disseminated, we're going to see arthralgias, as well as neurologic symptoms like sleep disturbances, vertigos, neuropathies. Some lab findings: elevated ESR transaminases, hematuria, proteinuria. Two-step diagnosis process. We're going to do an ELISA for IgG, IgM, followed by a confirmatory Western blot. And then doxycycline for adults, amoxicillin for children. And then for the more severe forms, we're going to add on IV third-generation cephalosporin, meningitis, carditis, arthritis. And again, I found this on the Appalachian Trail Conservancy's website. I just thought, as enjoyers of the outdoors, it's pretty interesting to see the overlay of the trail itself with Lyme prevalence, especially as you go through the Northeast US. Pennsylvania, I've heard, is also full of rocks and rattlesnakes. So interesting section of the Appalachian Trail to be sure. Borrelial diseases, some others, we've got Borrelia myomota, similar to Lyme, but rash is uncommon. We have Borrelia mayonii. This is found in the upper Midwest, was discovered at Mayo Clinic. We have tick-borne relapsing fever, also caused by some Borrelial species. This is found more in the western states, as well as Texas. And I found this funny. It was associated with rustic cabins, lean-tos, and caving in Texas. So I included a picture of a cave in Texas as the background. This is transmitted by the soft tick, has an incubation period of about 1 week. Fever is every 3 days, giving it that relapsing name. Headache, vomiting, myalgias, arthralgias, treated with tetracycline, erythromycin. Anaplasmosis is our next most prevalent. I ordered the tick-borne illnesses in kind of decreasing order of prevalence. This is caused by Anaplasma phagocytophilum. It's again distributed with the Ixodes tick, upper Midwest, northeastern US, incubation of about 1 to 2 weeks. Pretty non-specific symptoms, in this case, fever, rigors, headache, myalgias, vomiting, diarrhea, cytopenias, elevated transaminases, diagnosis through PCR immunofluorescent assay, immunohistochemical, or we can see the classic like intracytoplasmic morulae and granulocytes on the right here that characterize anaplasmosis, treated with doxycycline, which again, you'll see is like a pretty common theme among a lot of these tick-borne illnesses. Rocky Mountain spotted fever, probably one of the more severe ones we're going to talk about today. Rickettsia rickettsii, mainly found in the South Central US, but cases can be found everywhere in the US. This is the dermacenter and the rhipicephalus ticks, those American dog tick, brown dog tick, and the Rocky Mountain wood tick. Incubation is about 3 to 12 days. Initially, from like day 1 to 4, you have fever, headache, malaise, but after day 5, this can progress to pretty severe symptoms like coma, cerebral edema, pulmonary edema, ARDS, necrosis, multi-organ failure. And one of the most characteristic things about Rocky Mountain spotted fever is the rash. In the top right here, we see this kind of characteristic early maculopapular rash, can be found on like ankles, wrists, spreading to the body, also on the palms and soles. And then in the bottom right, we have the more late stage petechial rash, which we want to avoid getting to that stage and want to catch it early and have a high index of suspicion for treatment. Some lab findings: thrombocytopenia, transaminases, hyponatremia. Diagnosis is through immunofluorescence, PCR, immunohistochemistry, and doxycycline is going to be the treatment. Babesiosis, a little different, as this is a protozoal disease with a similar life cycle to malaria. Again, it's transmitted by Ixodes ticks, has a longer incubation period, 1 to 9 weeks, and symptoms include fever, rigors, headache, myalgias, dark urine, nausea, diarrhea. Again, pretty non-specific, but there can be mild splenomegaly, hepatomegaly, and jaundice in these patients. Kind of corresponding lab values here, some renal dysfunction, some blood dysfunction or hematic issues, and also elevated transaminases. We can see to the right here, kind of that peripheral blood smear, the classic Maltese cross that you can see for diagnosis, as well as PCR isolation of the parasite itself can be used. Treatment is going to be atovaquone, azithromycin for adults, and clindamycin and quinine for children. Ehrlichiosis, I couldn't find like a picture of the disease or like a good picture of the bacteria. So I decided to use a picture of Paul Ehrlich, who's the German guy it's named after. Pretty cool guy, actually. He did some awesome work in like, I think it was diphtheria and also treatment of syphilis. But going back to tick-borne illnesses, this is found, ehrlichiosis is more in the southeastern and south central US, the home of the amblyoma, that Lone Star tick, as well as Ixodes ticks. Incubation is going to be 1 to 2 weeks. Symptoms we can see, diagnosis pretty similar to the others, and doxycycline is going to be the treatment here. Tularemia is much less prevalent as a tick-borne illness, but one to be included for sure. And this one is found in all states except Hawaii. The dermacenter and amblyoma ticks are going to be the vectors for this, but can also be transmitted by other vectors. So deer flies, and then the one I'm very familiar with is rabbits that are the hosts for this disease and can also transmit it and often suffer in outbreaks of tularemia. Incubation is going to be 3 to 5 days. The fever, headache, malaise, myalgias, cutaneous ulcer, eschar can often be found at the site of inoculation. A lot of different lab abnormalities at play here. Couple ways to diagnose: direct fluorescent assay, PCR, or isolate a specimen. And doxycycline is going to be the treatment for adults, streptomycin for children, and streptomycin in adults if it's a severe case. We're getting down to the less and less prevalent ones. Powassan virus disease, I think, was about like 40 patients in 2019 that I saw. This is a flavivirus related to West Nile virus. It's found in the upper Midwest, Northeast, Ixodes ticks. Incubation of about 1 to 4 weeks of symptoms progressing to encephalitis. It's got a decently high fatality rate of 10%, and treatment is supportive. So lucky that it isn't more prevalent. A couple others we have: Colorado tick fever. It's a double-stranded DNA virus carried by dermacenter ticks in the Rocky Mountain region. Incubation of a day to a couple weeks. It's a fever rash, conjunctival injection followed by prolonged fatigue and weakness. Care is supportive. And then alpha-gal syndrome is basically a hypersensitivity reaction to meat. It's precipitated by injection of this carbohydrate molecule by the amblyomma and ixodes ticks. And like I said, you get a IgE mediated hypersensitivity reaction to ingesting meat and sometimes dairy products. So it chose to represent that with this juicy looking delicious steak. Just a quick recap of the American College of Chest Physician guidelines before we get into the recommendation strengths and before we get into the guidelines. So we've got 1 and 2 are going to be strong versus weak recommendation, and ABC is just going to show our level of evidence behind that recommendation. So as far as prevention of tick-based illnesses and tick bites in general, the first thing we'll talk about is behavioral prevention. So the main thing you can do based on expert opinion is wear long sleeve clothing, and then also light colored clothing to aid in the detection of ticks. This is inexpensive, has minimal to no risk. Another thing to do is to carry out tick checks within 36 hours and to bathe within 2 hours of being outdoors. Strong recommendation from the guidelines based on a case control study where this was found to be more likely in the erythema migrans free control group, these behaviors. One that was new to me was washing clothes at high temperature and drying at a high heat for 10 minutes. This can be effective for terminating life of the tick at all life stages. And then we also have avoiding areas with high grass or leaf litter, walking in the middle of trails, just trying not to brush up against grass or branches where the ticks like to hang out. And then educational programs in endemic areas have been shown to be pretty beneficial in reducing TBI incidents. And to the right here, we just have a picture of where you kind of look when you do a tick check. So this should be a full head to toe where you're not just looking at exposed skin, but you're looking at all the areas. So around the hairline, behind the ears, underneath the armpits, behind the knees, and underneath shorts and underwear. Tick and insect repellents. So a few ones that you guys are probably all familiar with. We have DEET. This has a low side effect profile. Seizure and neurotoxicity are potential side effects, but are pretty rare in practice. Concentration is going to determine the protection time here. So you're going to want to apply based on the guidelines on whatever DEET product you're using. And just some general safety guidelines: avoid under 2 months of age and use 10% under 12 years old. Picaridin is an alternative to DEET. Again, concentration is going to determine the protection. It has a superior safety profile to DEET based on some evidence, and it's less harmful to synthetic fabric. So DEET can ruin your expensive Arc'teryx or Patagonia Gore-Tex jacket. So picaridin might be a good alternative to that. Permethrin is also a treatment that's recommended. This is a treatment that's applied directly to clothing before you go out and helps with repelling ticks from that clothing. And this can be used in conjunction with DEET or picaridin as a tick repellent. And then some of the other tick repellents that they talk about were not recommended. They're either less effective than DEET and picaridin or don't last as long. All right, so final recommendations here: tick removal, vaccination, prophylaxis. I know we'll talk a little bit more about prophylaxis in, I believe, Danny's article, but looking at tick removal, we're going to want to use pointy tweezers, and you're going to want to do mechanical removal, grasping at the head of the tick, basically as close to the skin as you can get. And you're going to want to remove with straight, steady pressure, straight up from the site of where the tick is attached. So no twisting motion. And again, you want to get as close to the skin as possible to prevent squeezing some of the blood and potential pathogens into the bite site of the tick. There's no role for passive removal, so kind of wilderness myths like petroleum jelly, nail polish, isopropyl alcohol matches, anesthetics, ivermectin are not recommended. And it's recommended to remove within 36 hours of the initial tick bite. Vaccines for tick-borne encephalitis are available in other countries, not in the United States. And Lyme vaccination was trialed in the US for a while, but according to the guidelines, it sounds like based on both legal and financial reasons, it just wasn't feasible in the long run. Doxycycline is going to be the prophylaxis single dose. We'll talk a little bit more about that, but there are a couple of different criteria to meet. Other than that, it's just going to be watchful waiting. And for anything besides Lyme, doxycycline prophylaxis is not going to be recommended. And then final recommendation here, as far as evacuation goes, the main decision is basically going to be, are symptoms systemic or not? So if you're out for a couple of days, someone starts showing systemic signs of like a tick-borne illness, things like erythema migrans, cranial nerve palsies, chest pain, dyspnea, fever, arthralgias, especially with Lyme disease, there are some complications that you don't really want to be dealing with in the wilderness, like the Lyme carditis and the neurologic symptoms, especially Lyme meningitis. So it's good to get that person evacuated so they're able to seek proper care. So that's all I've got for the guidelines. Thank you all for your time, and would be happy to entertain any questions. And I'm sure Dr. LaRue would be happy to help out as well.
Great job.
Does anybody have any questions about the recommendations from the guidelines?
Yeah, I have a question. Hey guys, my name is Jordan. I'm an EM resident in Ohio. So you talked about prophylaxis with doxycycline. Is that recommended, or is that just kind of something like, oh, you could do if you're really nervous? Sorry, my baby's just jumping up, seeing what I'm doing. Is that something that's like recommended, or just something like, oh, if you're really worried about it, then you should do it? Or is it more like the malaria prophylaxis recommendations where if you're going to certain areas, then you probably should?
So it's kind of like malaria in the sense that you do it in certain places. So if you were in an area that you didn't have a very high incidence of Lyme disease, you wouldn't do prophylaxis. But like here in Southwest Virginia, we have a very high incidence of Lyme disease. So if I have a patient that comes in that's concerned about a tick being attached, the usual guidelines I think are about 48 hours, but like who walks around with a tick on them for 48 hours to like wait? So it's usually pretty unclear. I see one dose of doxy being pretty low risk. ID docs may disagree with me. If somebody comes in with a complaint of a tick attached, unless I can tell that it's a Lone Star tick or a tick that doesn't carry Lyme disease, I typically always offer them prophylaxis. And I will say my husband and I have a bottle of doxy at home. And if we pull ticks off, we definitely pop a doxy.
Thank you, appreciate it.
Jordan, I don't know if I can be heard or not.
Yeah, you can, sorry.
Hey, Doug Sword, I'm in Maryland, and I'm the Wilderness EMS Medical Director for our Search and Rescue Team. And we get a lot of tick exposures. And I agree, I don't have any issue with giving, a single prophylaxis dose of doxycycline. I think it's exceedingly low risk. There's really only one, as far as I know, there's only one New England Journal paper about it, but I do that.
Great, thank you, appreciate it.
I can't remember if this was included in the guidelines, but does anybody remember what life stage of ticks are the most high risk for transmission of diseases?
The nymph.
Yes. I couldn't really find much about why. My suspicion is they're really hard to find and small. My wife and I were hiking once, and it was before my LASIK eye surgery, so my vision wasn't as good, but she saw tons of little ticks on us and we kind of lost count. So we did the prophylaxis. we didn't see any attached, but we were just like, well, there is no way we're gonna find all these tiny little guys. So the nymphs are what is the highest risk. Anybody have any other ideas why it would be a nymph? That was just my suspicion.
Well, they talk about it in my paper that it is, they thought it's partly due to because of the size. The average time on person for the nymph was 30 hours in their study of like 400 something people, with adults being 10 hours. And we all know from, IDSA guidelines and CDC that until you reach that 48-hour mark, we're not really kind of considering it anyways. So, if the average of the adult on you is 10 hours, I mean, most of these are like, oh, look, I see it. And that's it. Take it off.
Any other question about the guidelines or other comments? Otherwise, Steph, do you want to run us through maybe a couple of cases?
Sure. We'll do a couple cases and then we'll. All right, can everybody see that? Is it in the presenter view?
Yes.
All right. These are all cases that I've either seen or one of my colleagues have seen. So some of the details have been changed a little bit, but I'm going to need some audience participation. We have a 45-year-old lady with the chief complaint of multiple complaints. Everyone is really excited to pick up that chart in the emergency department. And when you kind of narrow it down, you get mild headache, intermittent subjective fevers, myalgias, and notice this rash on their ankles and feet. So what do you guys think about this rash? Can you guys see the rash?
How about one of our students? Maybe a resident.
How about an erythematous non-blanching rash to the lower extremity? Does that sound good? So what's the scary thing you think about when you see a rash like this? Like the do not misdiagnosis, the person dies.
Meningitis.
Awesome, yes. So we don't want to miss meningitis. Luckily, this lady actually looks pretty good. And this rash, a lot of times is associated with Rocky Mountain spotted fever. The thing that's tough is only about 80% of the people come with the rash. And it starts out as kind of a maculopapular rash and then becomes petechial, and usually begins on the hands and wrists and feet and ankles and then spreads to the trunk. So classic triad of fever plus. A lot of these tick-borne illnesses were super tough during COVID times because everyone had fever plus. We kind of talked about earlier, the dog tick and the wood tick are your two vectors from Rocky Mountain spotted fever. So clinically you do labs and stuff, and we'll just say in this situation, the patient's labs all look pretty good. What kind of treatment would you guys want to consider for this person? Give you a hint, it's the thing that treats all tick-borne illnesses.
Doxycycline.
Yes, for the win. So here we have the distribution we talked about a little bit. So you can see here in Virginia, we get a lot of the American dog tick. So interestingly, not as much, I haven't seen as much Rocky Mountain spotted fever in Virginia, but I trained in North Carolina and we saw a pretty decent amount there. So basically all those normal kind of a little bit of everything complaints. And let's see, when you do get labs, so people can, early on, people are not typically super sick with Rocky Mountain spotted fever, but as the disease progresses, they can become very sick. When you do labs, you see neutropenia and thrombocytopenia, a lot of times hyponatremia. So definitely something to kind of keep on your differential when you get lab work back and someone's hyponatremic. And renal failure, you can see some bumps in the LFTs. If this is someone who's got a really bad headache and you end up doing a lumbar puncture, you can see some elevated protein with the normal glucose. So let's see. You were right, doxycycline, typically 100 milligrams BID for 7 days for a patient that's well, that'll be discharged. For someone who's not well, that's going to need to be admitted, typically 200 milligrams IV BID for critically ill patients that you're admitting to the hospital. So we'll do another quick case. This is one that I saw here in our emergency department. We have a 19-month-old female with skin rash times 1 week, worsening large macules with white center. Parents were complaining that she was sweaty and had a fever. She had been drinking fluids. This family was from one of our more hippie communities where they have had no vaccinations. And in fact, had seen the chiropractor for this child's rash, who directed them to the emergency department and believed in natural health. No joint swelling, no shortness of breath, no cough, not pulling at the ears, no URI symptoms. And here's a picture. What do you guys think about that? What rash is that?
Like a disseminated Lyme.
Yeah, so erythema migrans is kind of what you typically call the rash, but yeah, disseminated Lyme disease is definitely one of the things that you think about. For this patient being febrile and not vaccinated, we did a little bit more workup than you may typically do for a vaccinated kid that looks like this. Some vital signs, a pulse of 117, temperature 98.2, so not febrile in the ED, a little tachypnic. Got a urine, which was normal. CBC was pretty normal, maybe a little dry with anion gap of 20 and a CO2 of 17. LT is mildly bumped. And the good old procalcitonin, which was pretty normal. So what do you want to do with this child? What do you think they have? I think Janice called it out.
The disseminated Lyme with amoxicillin.
So you can do amoxicillin. Let's see, some quick slides about Lyme disease. It's the most common vector-borne zoonotic infection in the US. It's called by the Borrelia burgdorferi, which is a spirochete. It's found in the deer ticks and the black-legged ticks. Occasionally patients will bring the ticks to the hospital. For the most part, they usually don't. A lot of times they don't actually even recall the bite. And this lives in a deer, mice, and sheep reservoir. So that's what a black-legged tick looks like. And that's what the Borrelia burgdorferi looks like. That's what it looks like under dark field microscopy. You can see here in Roanoke, Virginia, we're kind of in the middle of the hotbed for Lyme disease. I think our Lyme prevalence has actually been markedly increasing with some of the changes in climate and increased ticks on deer around this area. And let's see. So depending on where you read, it's somewhere between 48 and 72 hours that the transmission of disease occurs. And thoughts are about 5% of people who have had one of these ticks attached for greater than 72 hours will actually go on to develop Lyme disease. But no one wants Lyme disease. Here's our classic rash. This is actually due to a sort of vasculitis. It can be at the site of the bite. Sometimes people will actually have it disseminated in other spots. About 60 to 80% of cases of Lyme disease have the rash. The important thing to remember here is that means like more than 20% don't have the rash. So absence of the rash doesn't mean you don't have Lyme disease. And you need to treat with antibiotics, doxycycline being the first line. I don't think Justin picked the my favorite article from AAP, American Academy of Pediatrics, that actually says Lyme disease is probably safe for kids with Lyme disease. So I typically now will treat them with doxycycline as well. Some of the older school pediatrics folks are still not super happy about that. But most of the new guidelines say that it's actually pretty safe for short courses for pediatrics. And then Lyme disease can have a bunch of different if you don't treat it early on, you can actually end up with a disseminated infection, which happens about 4 to 6 weeks after initial infection. And that's tough for patients because a lot of times they don't remember the tick bite. If somebody's untreated, about 50% of them will go on to develop a disseminated infection, which can be disseminated erythema migrans, like in the pediatric patient that we saw, can actually become like a Bell's palsy or facial nerve palsy, can develop like a septic arthritis kind of picture, or actually an AV block. So picture of facial palsy. kind of a little bit about the time course. So you can see in months, typically those first 2 months are kind of the localized, and then the disseminated comes later. If you're in a Lyme endemic area, this is going to be something that kind of remains on your differential if you have a non-specific febrile illness and a rash. And patients have kind of characteristic complaints in the spring and summer, really into the fall with the way the weather's been lately. All right, we'll do one more case and then go back to Journal Club articles. Is that cool, Justin? All right.
Yep.
So you have a 43-year-old healthy male who presents to the ED with syncope ×3. They're an avid mountain biker. And they do note having a recent febrile illness. What do you guys think? What else do you want to know?
Heart rate.
Awesome. Their heart rate is 46.
Sounds
Any
bad.
other symptoms?
I said basically, never had a problem like this. Sometimes they just start feeling kind of woozy, lightheaded, and then boom, they're out.
What's his glucose?
Glucose is normal. It's 100.
Other cardiac history or familiar cardiac history?
Yeah, no cardiac history, no family history, no
Okay.
hypertension. And they say that normally their heart rate's not super fast, like they're pretty athletic. It's usually in the 50s.
When we get to it, I'd love to see the EKG.
There you go. An example of the EKG. What do you guys think about that EKG?
Then complete heart block. Some type of heart block.
Yeah, I think sometimes hard without like some calipers or something to look at it on a computer screen, but yes, this is supposed to be representative of a complete heart block. So interestingly, I've seen 3 patients that have had this problem from Lyme disease in my time in Roanoke. 2 of them presented a complete heart block, and the one that this case represents actually was kind of going in and out of complete heart block. So what's the treatment for this? Should you rush them to the EP lab to get them a pacemaker? Or what should you do? Well, if it makes you nervous, putting the pads on the patient's never a bad idea. Makes the patient more nervous. Sometimes it'll make the heart rate faster. But this actually will resolve with treatment for Lyme disease. So if you're going to use an IV medicine for Lyme disease, anyone have an idea what you want to do?
Could do ceftriaxone.
Exactly. So this patient, I think after 3 or 4 days of IV ceftriaxone, the heart block actually resolved, and they went on to have no deficits. So these are the few patients that have complete heart block that you don't want your EP guys running to the lab to put in their pacemaker. You want to give them some time to respond to the antibiotics and get better. I also had like an 80-some-year-old guy that came in with complete heart block, and he was a farmer. So I thought maybe he had Lyme carditis, and in fact, he just had complete heart block and ended up getting a pacer. So you don't win every time with this, but pretty awesome to be able to fix heart block with antibiotics.
Yeah, I just have 2 comments. The first is something else that I saw, I think as a second-year resident, I wish to God I would have saved the EKG, but something pathognomonic to consider for tick-borne illness is also rapidly fluctuating heart block. So I had a guy going into second degree type 1, second degree type 2, complete, second degree type 2, complete. It was fascinating to see that. That's the first comment that I have with respect to kind of smoking gun diagnosis. But the second comment is this is another good example of how we can really impact patients' managements as wilderness medicine providers. Things like not putting in a pacer for something that can be easily treated with antibiotics, obviously not pronouncing a hypothermic patient dead, preemptively or too soon, not doing, fasciotomies for crotolid envenomations. These kind of pearls, I think, are really what makes us stand out as specialists in our field and really make a difference in people's lives. So
Yeah, I definitely agree. And I think you guys all, by just showing up and learning about tick-borne illnesses, especially in certain areas, are super prevalent. And it's really easy, especially in our current world, to see like the 18th person with a fever. And when you don't get that history about tick exposure, you kind of lose opportunity to potentially change their management by treating them appropriately with antibiotics. Awesome. I will stop sharing.
Well, thank you. I think it's fun to mix it up with some interaction in between presentations. Let's see, we got a case report and we got an article. Let's get into like some nitty gritty like research paper stuff. Danny, can you present your doxy article?
Yeah, let me pull that up. Let me share it. Great. Are we're seeing my PowerPoint slides? All right. So this is an article that was published in 2001 in the New England Journal of Medicine. It adds at this point in time to a growing amount of literature depending on looking at giving prophylactic treatment regimens to patients that are at risk for developing clinically significant Lyme disease. Other things that had previously been looked at was amoxicillin and tetracycline. And so they had decided to look at this using doxycycline based on some other work that was done, including work on animal models. But breaking it down step by step, obviously we kind of talked about some of this already. I'm not going to go into the Lyme disease since we discussed that. There does exist a vaccine, but it is costly. At least when 20 years ago when this paper was written, they were quoting $61 per shot. And so that was one of the impetus for them to kind of look at a prophylactic regimen, especially with doxycycline, which at that point was much cheaper. Like I had said, they did some other studies were done. Not only were they hampered by differences in things like the antibiotics, but they also had smaller sample sizes. And a problem that we have found with studying Lyme disease is that the infectivity rate is really quite low. And so you guys know from just looking at research methodology, disease processes with low incidences, prevalences, infectivity rates, things like that makes it particularly difficult to study these populations because you need to have super large volume sample sizes. The authors were well respected in the areas at that time, and it was published in the New England Journal of Medicine. So I think that does also lend to its credibility. This just reminds me of I was at my brother-in-law's wedding last year, and just chilling out at the night before dinner. I'm sitting there and I have a tick crawling on me. So it's, ticks, especially in the Northeast. I trained in Massachusetts at Bay State. So tick-borne illnesses were a huge thing to keep on our differentials, but they're definitely everywhere. I don't know if anybody has a sense of what kind of tick this is. To the best of my ability to identify them, I think this is a female American dog tick. So definitely not one of the ones known to cause pathogens as far as I remember. So breaking down the article in a more bite-sized piece, which I think is always helpful to do. So looking at it from a PICO perspective, the population was patients in Westchester County, New York, 12 years or older. Those under the age of 18 did have consent provided by a guardian. 12 and older who had a Ixodes scapularis tick removed from their bodies in the previous 72 hours. Here you can see the exclusion criteria, which is always important with respect to applicability, internal, external validation, and applicability with respect to where you're practicing. The intervention was 2 pills of 100 milligrams of doxycycline for a total of 200 milligrams versus 2 pills of placebo that was contained lactose. These were randomized by the pharmacy at the 2 treating institutions, 1-to-1 randomization. The outcome was the development of erythema migrans that at the site of the tick bite, evaluated at time 0, at time 3 weeks, and at time 6 weeks. That was the primary outcome. And then secondary endpoints occur. They also kept tabs of was erythema migrans occurring at a different site and laboratory evidence of Borrelia burgdorferi in the absence of erythema migrans. And they did this via a few measures. They did this via skin biopsy in some patients that actually grew Lyme disease. They did this by seroconversion with IgG and IgM in addition to like ELISA testing. So going into the nitty gritty of the results, the first thing, I think it's always helpful to look at their table 1 to make sure that randomization seems to have occurred at some statistic, at a point that seems to mirror the real life. And it seems that it did. I mean, the average age was you can see that they did have the youngest and the oldest kind of encompassing both groups, including in both the doxycycline placebo group. It was about almost 50-50 males to females, as you can see there in the second line, also matched. But in general, you can see that in the doxycycline and placebo groups, they're basically about equal, which is great. So that way you know that, for example, not all of the doxycycline group was bit by adult ticks, and all of the placebo group was bit by, for example, nymphal ticks, which would obviously, you could always make the argument, well, obviously there's going to be more in the placebo group, more of them were bit by nymphal ticks. But in case people aren't exactly sure the best use of table 1, I think those are some good examples of why you should always be looking at it. And I did want to say this is based on an intention to treat analysis as opposed to a per protocol analysis. So this seems, in my opinion, this seems to mirror real life a little bit more realistically, because just like in real life, you're going to have failure to follow up, et cetera. So breaking it down into the results that we care about, you can see here, table 2, I think, has the brunt of what we're going to take away from this, considering that it was, in fact, its primary endpoint. Table 3 is going to be the secondary endpoints that it looked at. Some things of note, I think, that stuck out to me. You can see that nobody became infected with clinically apparent Lyme disease or erythema migrans if they were bit by an adult female. Or an adult male, but there was only one adult male seen. What is important to take away from this is that this was actually the ticks that were studied, which was part of the criteria for this research in the methodology, was actually all of the ticks were analyzed by a medical entomologist. So I will get to why that might be a criticism. But you can see that all of the Lyme disease, clinically significant Lyme disease, appeared in the nymphal ticks. 1 out of 124 cases that were given that were randomized to the doxycycline group, and then 8 of the 142 that were randomized to the placebo group, with a statistically significant p-value of less than 0.04. Looking at table 3, we can see some of the secondary endpoints. Erythema migrans not at site of tick bite, 1 case in each one. A takeaway that they looked at from this was that because they looked at patients over 3 to 6 weeks in regards to the time frame in which they were following them up. They actually did not have an insignificant number of people that had multiple tick bites during that period. So something that people take away from this is that if you're in an endemic area for tick-borne illnesses and exposure and high exposure risk to ticks, the fact of the matter is you may just be bit by another tick even if you've already received prophylaxis. And the reason why they say that is because erythema migrans not at site of tick bite may be in and of itself a marker that you were bitten by another tick, because the vast majority of cases, if not all cases in animal models, the erythema migrans site appears at the site you were bit. Some other things, they've acute viral-like illnesses without erythema migrans, asymptomatic seroconversion. So the acute viral-like illness without erythema migrans is their takeaway is that maybe patients did have a mild immune response to something that didn't actually blossom into a full dermatologic kind of primary Lyme disease presentation, but that these patients did not actually go on to have any further complications. This is febrile episodes falls under, is kind of a subset of that. Not by the numbers here, but just kind of in with respect to rationale of thinking. And then I already kind of mentioned about the subsequent tick bites. These were patients that actually had a documented, they actually saw another tick bite them or was found on their persons within the study period. Some bonus calculations to kind of break it down with respect to looking at the tables and giving us our relative risks and absolute risk reductions. You can see here the calculations were all done just like we learned in our stat courses. That the risk in the control group ended up being about 3.2% in the patients that were bitten, which you can, I mean, off the cuff, is going to be a low percentage of patients that are going to be developing Lyme anyways. Risk in the experimental group is going to be 0.4%. Doing a little bit of quick math and subtraction, you get that there's the absolute risk reduction by taking doxycycline is you have an absolute risk reduction of 2.8%. 1 over the absolute risk reduction is going to give you your number needed to treat. And so the number needed to treat is 36. Something that they ran into, which is very important, is actually their confidence interval. They didn't give the confidence intervals in their tables, but they did mention it, I believe, in their their discussion of their study. But the confidence interval is really, really quite large. I mean, we're talking anywhere from a number needed to treat of 19 to 220 with a relative risk reduction of 14% all the way up to 160%. And then if you guys remember the reason why their confidence if you could think about like, oh, why would their confidence interval be so big? It's due to their sample size and also how rare the actual development of the disease is. And remember, if you want to pick out big differences between groups, your confidence interval will be much narrower. But if you're trying to pick out more finer differences in two treatment groups, then your confidence interval is going to grow unless you make the sample size, unless you increase the sample size. Adverse events, they also looked at, obviously of utmost importance when we're giving somebody a treatment, especially a medication. The doxycycline group had a significant number of adverse, any adverse events as compared to placebo. And you can see here, 47 people over the 17 that developed an adverse event in the lactose placebo group. The most common being nausea, abdominal discomfort, vomiting to a lesser extent. I thought they mentioned it, and I thought what was also interesting is photosensitivity is not in here, which is obviously something that I think all of us are somewhat well versed in, kind of telling patients, hey, I'm going to put you on doxy. You should probably take it with food, which will obviously help, I think, a lot with the abdominal type symptoms, but try to avoid sunlight because it will make you photosensitive.
That's the worst thing about doxy for malaria prophylaxis is people are typically going to tropical places and then they take doxy, and if they don't get warnings, their vacation is ruined.
Totally. No. And I mean, I practice down here in Miami, and I'll be honest with you, looking at our antibiogram, doxy is my preferred agent for community acquired MRSA. So, I have to tell, I mean, it's part of my, please pill esophagitis, photosensitivity, please take it with food. That's kind of I probably say that every 2 days. I don't know. But anyways.
Yeah, I don't mean to cut you both off. During our infectious disease journal club last month, our guest presenter mentioned that when he was guiding a trip to Africa, one of his own team members was taking doxy for malaria prophylaxis and got pill esophagitis and had to be actually extricated from Africa back to the US because they had such a severe case. So yeah, it is real.
I'll be honest with you, I hadn't heard about it until my wife was sharing some board questions that she was studying for her dermatology boards. And that's like a high yield point for them. I'm like, I didn't remember learning that, but sure. Thank you for the tip. So in summary, a single 200 milligram dose seems to be effective prophylaxis in the development of clinically significant Lyme disease. I talked about the limitations due to the small size, the sample size, but also the small size of actual infectivity that occurs. There were subsequent tick spikes that did occur. There was actually 59 out of 325 subjects. I forgot where the 325 comes from, because actually 400 and I believe 430 or 482 were randomized. I think what happened was they lost 100 to follow up in the 6 weeks period, because you can only, they couldn't actually take the full number by that point. Corroborates data that infection rarely occurs in attachment periods less than 48 hours. And I had kind of mentioned it already that the average time of attachment for the nymphal ticks was of 30 hours in this study, and the average time of attachment by adult ticks was 10 hours. So those are obviously are noticed much sooner and removed also sooner. Some limitations. These, like I had said, the ticks that were, all of the ticks that were looked at in this study were done by medical entomologists. So they were obviously specialists. If we're, I think we've kind of got a sense as emergency providers that our threshold to do certain things is a little bit less. I'd like to believe it's all for the benefit of the patient, but I think even legally, we want to make sure that we're protecting our patients just as we're protecting ourselves. I mean, how often do you guys give, tetanus vaccines? I'm not sure every single knife injury needs a tetanus, but we do these kind of things. So whether or not you feel comfortable identifying the specific tick and understanding that doxycycline is in studies shown primarily to be at least evidence-based used for Lyme disease and not the other, not necessarily all tick-borne illnesses. That's based on what tick it was that actually bit the patient. The study period, there was some concerns raised that they only had patient follow-up from 0, 3, and 6 weeks afterwards, that maybe it would have presented, what if it presented a little bit longer, but they actually used 4 times the maximum range of which Lyme disease presented in other studies in other animal models, just to make sure that they at least caught all of the erythema migrans. The authors also commented that they could have expanded the time period, but the fact is, being in an area that has so many that the rate at which people are exposed to ticks and getting tick bites, 59 of the subjects had a repeat tick bite occur within their study population in and of itself. So that would probably be very challenging to do. Some other thing, just kind of 2 bonus things I wanted to point out. There actually, I think one of the other members here tonight had mentioned that this wasn't really any other studies that looked at this with respect to Lyme disease and doxycycline and prophylaxis. There was actually an article that came out I found in 2020, published last year in 2021, actually, that looked at this specifically. I don't want to harp too much and go into that article, since I wanted to just focus on mine. But you can see that they looked at a significantly higher number of patients. I think they look 10 cases were found in 1,000 participants, 19 cases out of the 648 in the 10 cases in the prophylaxis and 19 out of the 648 in the treatment group. Some of the numbers are the same. You can see how the treatment is basically like a almost a little bit less than 1% coming into 1%. And then in the placebo group, it was reaching about 3. And I believe in the study that back in 2000, the study that I talked about, it was 3 point something percent. The risk reduction was 67%. In the paper that I talked about, it was 87. But you can see here with the higher sample size, the confidence interval was much tighter. And then although the number needed to treat back in 2001 was, I think it was 36. Here you can see the number needed to treat with a higher sample size was actually a little higher, it was 51. And then finally, there was a meta-analysis that was published last year looking at a few different prophylactic courses, putting it in a forest plot. Here, I think just for simplicity's sake, I just wanted to reproduce the forest plot from it. If we just focus at least from the oral single dose doxycycline, which is the second group, you can see the study that I talked about first here, where the line is dangerously or just about touching the 1 with respect to the risk ratio. But in the harms group, harm study that had a lot more participants, you can see that it does tend to favor, favor treatment. And so that's all that I have for you guys. Is there any questions with respect to this study specifically?
Be interesting to see if anyone ever repeats it with more pediatric patients. I don't know if that other study you found in 2021 included kids too.
I don't remember. I have it pulled up. I'll look right now. I have it saved here. The other thing that I wanted to I forgot to mention, when you're looking at this kind of data on this topic, the data, they make there's a lot of people that talk about obviously the cost effectiveness of doing this. If you're in an area that is a lot less endemic than Westchester County, that in and of itself, taking into consideration kind of the low risk of developing, actually of catching Lyme disease, may influence your decision. They in this Westchester County, it's considered hyper endemic, and it's technically one of the incidents, at least at this point in time when the study was done, was one of the highest incidence of Lyme disease in the world, and that's between 0.5 and 1 reported case per 1,000 persons per year. People criticize about applicability towards Europe and things like that. But let me see if I can pull up just double check the inclusion for this other one.
It's interesting because like my understanding is like amoxicillin, which is what we used to always do for Lyme in kids, like is not effective as prophylaxis. So that doesn't really help, but the doxy probably would be. So it's kind of cool.
Yeah, I saw that too. I got the same sense that amoxicillin was really just not, from what other studies have shown, it's just not effective. It's not worth the time, honestly. 8 years old. The individual is about at least 8 years old.
Also use the same
eligible for the
kind
study.
that people usually talk about for doxy.
And I've made, you had mentioned about, being much more friendly towards doxycycline used towards pediatrics. I have the same sense after that really large AAP article that came out a few years ago. And the fact of the matter is, when the idea that we got, tetracyclines are going to cause tooth discoloration in kids, the fact of the matter is that was done with the prototypical tetracycline, which was in fact tetracycline, and it was not doxycycline. So this seems like the risk is just really clinically insignificant when using a modern tetracycline, of which we all use doxycycline now.
Well, Justin, I have got two more cases. If you want me to, I'll show them real quick.
Yeah, I think that would be perfect. I just wanted to mention real quick, we have 2 dogs here in our household. Both are on their own little tick prophylaxis meds. I would highly recommend the tick checks that are mentioned in the guidelines, and do your doggy tick checks, because our golden retriever brings home a tick about every time she goes outside. So you can check yourself and make sure you check your pets.
Yes, we have one dog and lots of ticks in our house. They're like crawl. She loves to run through tall grasses, which happens to be where ticks love to quest from. So this is actually a case report that was in the New England Journal of Medicine. But a similar case to this happened when I was actually a fellow down at Medical College of Georgia that I heard about. And then I'll tell you guys about one other case that's similar. So this was a previously healthy 6-year-old girl, had a tingling sensation in her fingers, and 6 hours later she began to stagger and fall. The next day she was unable to walk without assistance. Brought to MCG about 30 hours after onset of her symptoms. Initial exam was alert and afebrile, but had truncal instability, wide base gait, and ataxic gait. She was unable to walk without support. She had about 4 out of 5 strength in the arms and legs, proximally and distally. Had some dysmetria of the arms when she did finger, nose, finger. And muscle reflexes were diminished at the left knee, but were normal elsewhere. The findings of sensory nerve and cranial nerve function were normal as well. I'm not sure who decided to do a rectal exam on this 6-year-old, but that was normal too. So what do you guys think about this? Any thoughts? So this would be kind of a weird, puzzling case, I feel like, as an ED doc, if someone brought this child in. What kind of things are on your differential for like a kid with some neurodeficits? So I would think toxic things potentially. Did she get into something? Drugs in the house. Then you got to think about kind of a weird brain lesion. All the other, you kind of look at these neuro findings and they don't necessarily point you to something obvious. Then something maybe more infectious or encephalopathic. Is there anything else other people think of that I'm missing?
A vitamin deficiency, like a pernicious anemia or something, like a B12 deficiency or something else like that. Sometimes you can get some neuro findings.
Yeah, that's definitely a good thought. So I'm not sure if this case or the case that I actually heard about at MCG was actually diagnosed on MRI. And what was diagnosed on MRI? They found the attached tick on MRI. Real expensive test to replace your physical exam. But this is actually tick paralysis. There's 43 different Ioxidae species that have been implicated. actually happens more often in animals than humans. So for you dog owners, if your dog ever starts acting funny or like they have a neurodeficit, definitely check them for ticks. Happens in the US and Australia, more often children than adults. I think that's probably due to body mass. And basically the tick excretes a neurotoxin, and you get an acute ascending lower motor neuron paralysis, and you can get some CNS effects as well. Usually happens about 5 to 6 days after attachment of the female tick. And basically over 24 to 48 hours, you get ascending symmetrical paralysis and loss of deep tendon reflexes. And this can be fatal if you don't diagnose it. The good news is the treatment for this is really easy. You just got to take the tick off, and then provide supportive care, and doesn't really require much aside from that. Need to think about other neuromuscular disorders such as Guillain-Barré, myasthenia gravis, botulism, also the hypokalemic associated paralysis. If you do an LP in these kind of patients, you're going to have normal CSF. And yeah, in this case, and the case that I knew about from Georgia, the MRI was the answer with the tick being found. Interestingly, earlier this summer, one of the nurses that I work with down in Rocky Mount, Virginia, had a daughter that all of a sudden was, I think she was 10 or 12, and she refused to walk and said she was too weak to walk. Was actually seen up in our children's hospital, and my colleagues didn't really find anything wrong with her. They did not get an MRI, but they got lab work and kind of took it to be like a hysterical preteen, and discharged her home, which I was pretty surprised about, as I probably wouldn't have discharged a pediatric patient that wasn't walking back home, but I think they felt that it was more supratentorial than anything else. And her mom was telling me all about it, and she said that she was helping her take a shower because she couldn't stand up in the shower and was in the bathtub. And when she was helping her wash her hair, she actually found a tick on her head. She removed the tick, and 24 or 48 hours later, her daughter got better and was able to walk and everything again. So kind of clinically, that made the most sense for diagnosis for this, which is pretty interesting, and just something that to think about when you have a kid that's not quite acting right. So, all right, and this is the last one. We've been seeing a lot of this. 28-year-old presents with hives, shortness of breath and vomiting, denies soap, new soaps, detergents, new foods, new medications, or history of symptoms like this before, no known drug allergies. What else do you guys want to ask this patient? All right, it's a journal club about ticks. So why don't we ask him about some tick bites? He does attest to doing stuff outside, does recall a tick bite. So then what else do you want to ask him about? Even if they don't recall a tick bite, I typically ask what the last thing is they ate. Because what you'll find is with this disease, it's not necessarily that you eat something and have an immediate allergic reaction. Typically it's lags several hours. So maybe this kid comes in, or this young adult comes in at, 4 p.m. and he notes at 11 p.m. or 11 a.m. he ate a cheeseburger. That would be sort of the time course that I would expect for this. And like all anaphylaxis, before you make the diagnosis, you're going to treat it like anaphylaxis. So epinephrine, steroids, and antihistamines. And what he has is alpha gal, which comes from the Lone Star tick. It's the tick that has the little white spot on his back, found pretty prevalently in this area, not as much in Texas. This causes a red meat allergy. Kind of the test to prove it is called, at least in EPIC, the alpha gal panel, and it tests for all the alpha gal things. If you have a patient that comes in and has anaphylaxis and you don't know why, I would encourage you, first of all, to treat their anaphylaxis. And if there's somebody who believes they've had some tick bites and it seems to be proximate to eating red meat, it's probably good to do this testing and then really counsel your patient to avoid red meat until the test results come back, or they can follow up with an allergist, because these reactions typically get worse and worse and worse with every exposure. So sometimes even if you talk to the patient and get a really good history and the patient has a good memory, they'll remember having like maybe some itching or something after maybe the red meat meal they had before. When counseling patients, if they're not sure about what red meat is, basically anything with 4 legs is red meat. So that's pork, beef. Gotta avoid those. Some people with severe allergies actually claim allergies to like heparin and other medical medical materials. So that's something that's a little bit tricky. I had a lady that was having ACS that claimed that she had alpha-gal and couldn't get heparin. So that makes you stop and think a little bit more about what you're giving people. Not everyone is that severe. Some people will actually get better and will be able to eat red meat again later in life, but usually that's with the guidance of an allergist. But definitely something that the prevalence is really increasing, at least in the Southeast. Sweet, any questions? I think there's one more journal article, Justin?
Yes. Kristen, do you feel ready to present your article?
Yes.
Cool. Take it away. I think you should be able to share screen.
Okay. All right, so we have tick-borne relapsing fever with a case of ARDS. So being a case report, this is an N of 1. However, there has been other reports of ARDS with tick-borne relapsing fever. So with that, we're going to start off with our case, then we'll kind of go through what tick-borne relapsing fever is, including what location you're going to find it in, the transmission, the virulence, symptoms, and then in pregnancy, what are some different considerations? And finally, just kind of some takeaways, or at least my takeaways after reading this article. So the year's 2007, you are in Spokane, Washington, and you are caring for a 59-year-old female who presents to your hospital with a headache. She denies any fever or rash, and in the ER, she gets some basic blood tests, which include platelets of 19, white blood cell count of 4.5, and a hemoglobin of 12.6. They did some imaging of her brain that had a negative brain MRI. She got a bone marrow biopsy due to the low platelets, and that was consistent with ITP. So with the leading diagnosis being ITP, they treated her with prednisone. She got better, her platelets responded well, went up to 250, and she was discharged home. So now we're going to put our hematology hat on, and she follows up in your clinic. However, she's not looking as well as you probably would have anticipated. She actually has a fever of 39 degrees Celsius. She has intense thirst, some confusion, and such severe myalgias that she can't even walk. So you're in a hematology clinic, so of course you're going to get some blood counts, and you're now finding pancytopenia with a white count of 1.3, hemoglobin of 8.9, and platelets of 11. A couple other labs that you checked found that she has an increased ALK-Phos, increased AST and ALT, and as well as aldolase. So you repeat the bone marrow biopsy in your clinic and then send her off to the hospital. So for her second admission, since this is sounding a little bit less like kind of ITP, you kind of stop and get a little bit more of a history and find that recently she was clearing out some knapweeds near her home. And she kind of noticed that she's been having more chipmunks around, a bigger chipmunk population. They seem to be doing pretty well. She lives in an upscale kind of forested neighborhood, denies any camping, sleeping in rustic cabins, or tick exposures. Since she has a fever, you ask about sick contacts, and she notes that somebody else in her house had a kind of brief fever right around the time when she was initially hospitalized that first time. And at that time as well, she did have a neighbor who had recently went to Nevada and was hospitalized with a fever and some respiratory distress that was so severe that actually needed to get intubated and treated with antibiotics However, they never quite figured out what the cause of her respiratory failure, found an organism for that. From a travel history standpoint, she visited the Galapagos about 3 months ago, but no one from that trip had been sick. And then 3 years ago, she went to Africa, but again, has been healthy since that time. Did your best physical exam and really just found that her temperature was 39 degrees Celsius. She had a little bit of some confusion and mild splenomegaly. So you get some labs, and with some of your labs, you get a blood smear. And in this blood smear, you notice all these little like purple squiggly things. And actually in her bone marrow biopsy, there's also little purple squiggly things. You check for Rocky Mountain spotted fever, ehrlichiosis, CMV, EBV, parvo, and HIV, and all those came back negative. However, her PCR was positive for Borrelia hermsii. So you sent off some more blood to the CDC, and that actually shows she's probably had this infection for a couple weeks based on kind of a strong IgM kind of antibody response, and then kind of an increasing IgG profile as well. So with the diagnosis being made of relapsing tick fever, you decide to start her on some doxycycline and some ceftriaxone. So the doxycycline dose I got was from the CDC, and that was 100 milligrams BID for 10 days. And then the ceftriaxone is 2 grams per day for 10 to 14 days. And you do the ceftriaxone when you have neuroinvolvement. And so when you start treatment for this, you need to watch out for this JHR reaction, which is essentially where the first 4 hours after you give the antibiotics, there's this huge inflammatory response as the body's starting to fight off the infection. And it can cause, really severe fevers, chills. The person looks super sick. But the big thing you need to watch out for is cardiovascular collapse, where they become super hypotensive. And so you could give them, 2, 4, even 6 liters of fluids really to try and help if they develop this. And it can happen in, I think they said about 50% or so of patients. So it's not kind of an insignificant kind of number. And unfortunately, like giving steroids or waiting till they're not febrile, none of that seems to really help with this reaction. But fortunately, our patient did not have this reaction. However, there was a twist in the plot. So 76 hours after starting antibiotics, you're called to bedside because the patient's oxygen saturation has dropped. She's also tachycardic. However, her blood pressure at least is 140/90, so you can breathe a small sigh of relief there. You get a chest x-ray that looks like this. It looks like a whole bunch of white fluffy infiltrates. So you're kind of concerned about some pulmonary edema. And with that, you decide to get an echo and found that her EF is 20%, which doesn't really fit with, having heart failure previously. She has some moderate tricuspid regurgitation and her pulmonary artery pressure is 59. You get an EKG and that shows no infarct, no myocarditis, and her cardiac enzymes were negative, and she's still pretty thrombocytopenic. So you put her on some oxygen, 100% FiO2, you check an ABG, and this is what you find. So given kind of this acute respiratory alkalosis, you talk with the cardiologist and the pulmonologist, and you're like, I'm pretty sure this is ARDS, and they are like, yeah, I think you're right. So the decision was made to intubate, provide some PEEP, and then 4 days later, she was able to be extubated. Unfortunately, during this time, she did not need any vasopressors. So her road to recovery was not the smoothest. As she continued to wean off oxygen, she had mild DIC, recurrent pancytopenia, some LFT abnormalities, which were thought to be due to a multi-system organ failure, probably due to the hypoxia since she was normotensive would be my guess. She was hyponatremic. She was 141, then went down to 117. And with that, she had associated altered mental status, and she had a normal head CT. They gave her some normal saline and some fludrocortisone, and she improved. They repeated her smears and showed no Borrelia, and she completed a 14-day course of ceftriaxone. So congratulations, it's day of discharge, and she has a normal physical exam. She's still on the doxycycline, which is a normal chest x-ray, normal labs. her EF has actually improved to 55%, and her pulmonary artery pressure is improving to 36. So feeling pretty good. You follow up with her 5 months later. She actually had some unilateral hearing loss kind of during the hospital stay, kind of part of that neuro involvement. And the ENT doc thinks that that's likely going to be kind of a permanent sequelae for her. And you get some PFTs and those actually come back normal. So overall, it sounds like a fairly good recovery for her, despite what seems like a pretty severe illness. So what is relapsing fever? So relapsing fever is kind of your broad category, and then there's kind of a couple different subcategories. And I think there's actually more than this, but these are some of the main ones. So there is the epidemic or the louse-borne relapsing fever, which is a human-to-human transmission by the Bowdy louse. Now, long time ago, we used to see a whole bunch of this. However, that's not really the case anymore. It's not really seen in the US. Maybe you might see it in a refugee type of population or somewhere where there's a lot of really close kind of human quarters, human contact, but really not one that we're going to be seeing even in patients who are traveling. For the heart tick relapsing fever, so you're basically thinking anything, all of your risk factors for Lyme, including the same type of tick, same type of mammals that will spread it to humans by the tick, is the same thing for this disease. And then the one, I don't know if it's the most common, but the one that, kind of gets the most attention is the one we're talking about, the tick-borne relapsing fever. And so that's where you have a rodent. For our patient was those chipmunks, but could also be, voles or squirrels, that gives it to a human by the soft tick. And so they tend to be in this specific gene. So the O. hermsii is the one that was for our patient. And I think one of the more common ones, but there's kind of a couple different ones that are all in that same kind of genus. So the location that you're going to find this is primarily on the West Coast. And so the most common states are going to be California, Washington, and Colorado. You can also see it kind of in the southern BC, in the plateau regions of Asia, Mediterranean countries, as well as in Africa. This case specifically was a part of the Brown Mountain in Spokane, Washington kind of outbreak, which I think was a fairly larger outbreak, in that there was this was one of 4 cases. So not like huge, but this disease kind of in and of itself there's not a large incidence of it. This isn't a nationally reportable disease, so we don't know the true incidence, but it is reportable in, I believe, 11 states, and kind of all on the West Coast where this is found. And so I think this kind of brings a good point about reporting and the importance of reporting, because you don't want to test for every single disease every single time, because that's wasteful, but you're never going to find something if you don't test for it. So you're kind of always in that conundrum. However, if with a reporting system, you can know if the hospital in the county over, a couple of counties over, is finding this, you might be finding it as well. And so it can kind of increase your pretest probability of if your patient, might have this type of disease. I think the other big thing is to really then be able to identify these populations and kind of work on control. So kind of educating people who might be in that area so that they can hopefully identify the symptoms, get help earlier, and get treatment earlier to hopefully have a less severe course of illness. But also then to try and provide kind of some prevention. So rodent proofing your house is a great way to prevent this, especially when you kind of think of your classic board question being kind of the male that goes to his rustic cabin in the coniferous forest somewhere in the mountains, like 1,200 meters up or so in the Western US. And so from the Washington Department of Health, they recommend kind of eliminating any of those nests, eliminating any food for rodents, including the food in the house, making sure it's in nice seal-proof containers that are hard to chew through, sealing any holes in the foundations and walls, placing different metal screens and a thick caliber gauge again, so that nobody's going to be chewing through that. But then also having a nice like gravel border kind of around your house can also help. So getting back to kind of this tick. So what makes this tick so special? Well, based on this picture, I think this tick, probably just had the best Thanksgiving feast of its life. And they are obligate blood feeders. And they are also a very generous tick in that they will pass this infection off to their offspring. I know, super nice. So they're also very persistent and they can survive 20 years without feeding, which is pretty impressive because that's definitely not something I could do. And they'll remain infectious for 10 years. So it's a pretty long time, basically most of its life. Unlike, Lyme's disease where the tick is on for days at a time, these will attach 5 to 20 minutes. They're done. It's not a painful bite and it happens at night. So a lot of times you're not even going to know that you got bit by one of these ticks. And what about this bacteria? So you can see here that's a cute little gram-negative kind of helical bacteria. But it too is elusive in that kind of every time that DNA is read, it will make a different antigen or kind of variable major protein. And this is really why you get those recurrent fevers. And this is something that we call antigen variation. So what does this kind of look like? Well, you get bit by the tick, might or might not know it. Maybe you develop this pruritic kind of eschar at that site. Again, this tick's a couple millimeters. But if you do get that little like eschar, it quickly resolves. A quarter, maybe a third of people are going to get a very non-specific, rash, erythema multiforme, maybe petechiae. So nothing kind of really too specific. And then about a week later, they get the fevers. And these are going to be high fevers, greater than 39. They're going to get drenching night sweats, thirst, and all of that's really correlating with this bacteremia or the spirochetemia. They're going to have, shaking, severe headaches, myalgias, weakness, arthralgias, upper abdominal pain, photophobia, cough, nausea, vomiting. Basically, it sounds like the person feels pretty miserable. However, all of these are pretty non-specific, right? I could be talking about somebody who has COVID. I could be talking about somebody who has flu, who's septic from some other source. So nothing is really kind of, saying, hey, this is, relapsing tick fever at kind of that initial presentation. So their body goes, fights off kind of whatever antigen is in this, kind of in the environment, in the bloodstream. And then you have kind of this crisis phase where you have an abrupt kind of stop in the symptoms and you no longer have a fever. However, kind of during this afebrile period, the spirochetes are still living in the liver, the spleen, the bone marrow, and the nervous system. So while all of it's living there, it's kind of undergoing that antigen variation. And so a different part of the DNA is being read, or somehow with kind of the change in the DNA, it now has a new antigen that kind of pops up, where again, your body's going to find that new antigen, try and fight that off. And the cycle can repeat itself up to 13 times, if left untreated. So it can be pretty impressive. So this article specifically was kind of talking about the ARDS component. And is this rare? Is this common? And I think it really depends on how you look at it. So in all of the patients that you are going to take care of with ARDS, relapsing tick fever is not going to be most of them. And that's going to be a pretty rare kind of diagnosis in your patients with ARDS. However, when you have a patient that has relapsing tick fever, 5 or 6% of those patients might develop ARDS. Again, we don't have necessarily great kind of data, but what the author was able to come up with was in the Lake Tahoe area, about 5% of the 65 cases, and in Washington, about 6% of the 46 cases had this. This is kind of more of a newer finding in terms of, I don't think the first case of ARDS associated with this relapsing fever was found until 2001, I believe. And then it wasn't until 2007 where the CDC's Morbidity and Mortality Weekly Report actually had a series of 3 cases that they kind of reported on. I think they had another like 3 cases in Washington, and then plus there was this one that we talked about today. So again, there's definitely cases out there, but it's not like it's a huge, large population. And part of that is because the tick fever isn't a huge, number of patients either. In Washington, it's anywhere between 1 to 12 a year. And I think it was maybe like 50 in the US a year or something. So it's not a lot of patients. Other symptoms, which a lot of these symptoms is what our patient had. So neuro, about 10 to 40%. Can it be meningismus and facial nerve palsy being common, but it could be hearing loss like what our patient had. From a cardiac standpoint, so your carditis, really kind of an unclear mechanism. Is it due to the sepsis, the ARDS, the cytokines, something else? From heme, you can have that, a left shift or the thrombocytopenia. And then the electrolytes, the hyponatremia is thought to really be due more to a dehydration, resulting in an increased ADH. And that can happen in about 56% of patients. In pregnancy, you are at a higher risk of having a miscarriage, preterm birth, or perinatal morbidity. And the proposed mechanism is placental invasion by the spirochetes, leading to thrombocytopenia, leading to a retroplacental hemorrhage. So kind of with all of that being said, what were some of the takeaways that I had? And so one of them is really location. So location, 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 until you put an airplane into it, then all bets are off. But that's where you get a good history. So, kind of knowing if you're on the East Coast, this is probably something you're not going to have to worry about. If you're over in Washington or California, it's something you should have in the back of your mind. And if you have somebody who's traveled and you don't remember what's over on the West Coast, you can look up the CDC's maps to kind of really figure out what else could be going on. And then with getting a good history, good physical exam, that's always the right answer. And I think the big history part is going to be the fever, relapse, afebrile period, repeat fever kind of combo. I think this also can really highlight a good reporting system. And I think especially when you have kind of symptoms like ARDS that have, potential things that we'd really want to be, if you're in a rural community, is this a patient you want to keep that has the potential to have ARDS, or kind of having a higher suspicion to then transfer them early can be helpful. And then just to be able to diagnose it, often. I suspect that there's probably, patients that have this diagnosis that we're missing or are treating with doxycycline for, where we're thinking it's something else and they get better. So I think that's an important thing. And then kind of prevention, which really goes along with the reporting. If you don't know it's there, how do you know how, to prevent it? And then I think the last big thing is kind of trusting your clinical skills. So let's say you didn't attend this presentation, you maybe learned about this once in medical school and then totally forgot about it, just recently moved to Washington. This wasn't, kind of ever on your differential before where you did your training. Knowing who's sick and who's not sick, knowing when something isn't fitting kind of, the natural course of illness or disease or treatments. And then this, I thought that this case didn't really highlight that there was any changes in how you would manage ARDS, how you'd manage hyponatremia, how you would manage, carditis. All of that, is probably, at least kind of from my, guess, is that it's all going to be the same that you would for a lot of other disease processes. And so even if you don't have the diagnosis, you sent off the titers, the serology, you sent off the smear, but you don't have it back, that we can still kind of manage it the same. And really the big difference is that JHR reaction that, would be kind of the big kind of watch out for. However, that could also maybe, aid in your diagnosis as well. So with that, what questions do people have?
Any questions or comments, anybody? Nice job, and thanks to everybody who presented tonight. I think that's one of the cooler disorders that the ticks can transmit. Lyme is so often talked about, and I don't want to say straightforward, but it's just so commonly discussed that it just kind of makes sense to us, I guess. But this one's just kind of bizarre, and then it can alter its composition over time, which is somewhat frustrating, I suppose.
Or just terrifying. I'd go with terrifying.
And it was just from like a nerdy microscopy view, that was a beautiful microscope picture that you posted there.
Or what if you gave the antibiotics maybe for not being 100% sure what you were treating and you got that kind of reaction? Like that's definitely like the not what you would expect.
I think that's one of the big things I was thinking if I was out, in the wilderness, and, had somebody who started to have, some illness, like, what if what if they took doxycycline and then had that reaction out there? It's like, not, what I'd want to deal with in the wilderness.
Hey, Justin.
Yeah.
Hey, CJ Ogier. I just wanted to thank Stephanie. Those were great cases. Kristen, I really enjoyed listening to you present. I think there were no questions because you told us everything. And as an orthopedic surgeon who is wilderness medicine is like my hobby. There's no role for it in my daily job. So I learned a tremendous amount from you guys tonight. So thank you very much.
I don't know. I've definitely seen some Lyme disease masquerading as sort of a weird looking septic arthritis, which is definitely always puzzling to us and orthopedics.
Well, I was sitting here listening in with my 10-year-old as we're doing dishes and cleaning up in the kitchen. And then y'all are asking for more signs and symptoms. And my son and I are going, any joint pain? Any joint pain?
Awesome.
Steph, did you have any other cases you wanted to go over, or with almost at the 2-hour mark, do you think
I think we're good. I think those are most of the cases. They're pretty representative of most of the things I see. I would urge all of you guys, as you see wilderness medicine things, I just have a really big PowerPoint presentation of all kinds of different wilderness things I've seen throughout the years, and keeping pictures of EKGs and interesting x-rays and stuff like that are de-identified. It's pretty cool when you get to share things with other people in the future.
Mm-hmm. As far as the academic content of this journal club goes, we have reached the end. I just wanted to mention, I do see some new names here in the participant list. Anybody here joined for their first time?
I did.
Yeah, I also
joining. Who else was that?
Good.
No. Who else? I saw Janice. Who else was our first time?
Oh, this is also my first time joining on as well. Thank you guys for hosting us.
Yeah. Where are you joining from?
I'm joining from, I'm an MS1 over at Duke. So
cool.
I got you guys email forwarded to us.
Yeah. So. For the other new people, I was just checking to see how you heard from us to make sure we can keep the word out, continuing to keep a strong group of core participants and always looking for more interested parties. Just in other news, like Instagram just recently started. Hopefully we can keep people engaged that way. Working on a way to make it more concise and one means of registering, finding calendar events, prior content, YouTube uploads. So working on that should come out soon. Otherwise, our next session is this coming month, December 29th, on toxic plants and plant-induced dermatitis. So if anybody's interested in joining both as a participant or a presenter, just let me know, and the registration form is available. Otherwise, I'm going to stop the recording. And if anybody wants to chat and talk about anything or ask any questions, go ahead. Thanks for joining, everybody.